everybody to the first grand round session of the academic year. Today I'm going to talk about renal functional reserve and renal stress test. This is one of the favorite topics of Dr. Bihorak. I wish she was here, but she went to attend some meeting. So what does renal functional reserve mean? It means capacity of the kidney to increase the glomerular filtration rate in response to pathological or physiological stressful stimuli. And it can be clinically assessed by after giving an oral protein load or giving intravenous amino acid infusion. So basically, it is the ability of the kidney to increase its glomerular filtration rate in response to stress, and stress usually elicited in the form of protein loading. And it can be defined as the difference between the peak or stress GFR that is attained after giving protein load and the baseline GFR. So what's the importance of this renal functional reserve? In situations where there is hyperfiltration, like pregnancy, diabetes, solitary kidney, so renal functional reserve might be completely or partially used up to maintain the normal or supranormal renal function. So even though we are clinically seeing the normal GFR and normal creatinine, the kidney might be using up its residual potential to keep it normal. So as it says, in people with solitary kidney, even though the 50% of the nephrons are lost, remaining 50% of the nephrons will work harder and use up the residual renal function and keep the GFR within the normal range. So this way, this test might represent early and sensitive marker to assess the functional decline in the kidney, because we are seeing a change in the renal functional reserve prior to we are seeing change in the creatinine or GFR. So it might be an important tool to evaluate ability of the kidney to recover after the AKI. So now, yeah, I'll go after the definitions of AKI and recovery of AKI. What are the current definitions and how they might change in a more clear way. So what is the definition of baseline GFR? So as we said, renal functional reserve is difference between peak GFR and baseline GFR. So the baseline GFR is the GFR value recorded under normal dietary and hemodynamic conditions. It depends on age, sex, body size, race, and the normal GFR is said to be about 120 mil per min in men and about 110 mil per min in women. However, it's not practical to pinpoint somebody and say this should be your normal GFR. So we can just statistically define average GFR of a cohort of healthy subjects. So on an average, it's about 120 and 110. And there is also the concept of age-related decline in GFR. After the third decade, we all lose about 0.8 to 1 mil per min per year. That's why we see some patients in our CKD clinic who are referred to as 80-year-olds with eGFR of 57. Most of them we just say that it's probably age-related decline in GFR. This patient doesn't have significant, clinically significant CKD. And these rates of decline are similar. Though they are similar in CKD, they are lower in the healthy males compared to the healthy females. And as said previously, the serum creatinine and GFR remain normal till at least 50% of the nephron mass is lost, because all this time the residual renal function or renal function reserve is being used up by the remaining nephrons. So the kidney stress test. So renal function reserve is the basis for the stress test of the kidney. And so this concept dates back to in 1980s, where Bosch et al. Showed that high protein intake leads to significant amount of increase in GFR. They compared individuals who were given either vegetarian diet or high protein diet. Usually normal people display a significant increase in GFR after a protein load, which is usually defined as 1 to 1.2 gram per kg. You see a rise in GFR 1 to 2 hours after the protein load. And you can see this renal functional reserve as analogous to cardiac functional reserve. And we do the cardiac stress testing very often in clinical practice. And Same way as heart increases its cardiac output in response to stressful stimuli, kidney increases the uses the residual functional reserve. So this table just briefly says the stimuli affecting the heart and kidney. Heart is usually affected by the pregnancy, exercise, high altitude, sepsis, hypertension, blood loss, valvular disease, etc. And kidney response to stressful stimuli like high protein intake, high fluid intake, pregnancy, aging, high cardiac output, drugs, etc. So basically, for the testing, we are using protein as stressful stimulus. So in physiological or pathological states like pregnancy or diabetic hyperfiltration or hypertensive hyperfiltration, renal functional reserve allows increase of GFR of whatever residual nephrons are there, and it replaces for the lost function. So that the elevation in creatinine or GFR is not apparent until about 50% of the nephrons are lost. So RFR in elderly. So in 1993, Fleischer et al. Compared the baseline and stress GFR in young and elderly healthy people, and they found that in elderly people, though the baseline creatinine was near normal, but the renal functional reserve was used up, and so that shows that young people have more reserve and old people have less reserve, and during the process of getting old, they are using that residual function. Renal functional reserve in pregnancy. In 1988, Ronco et al. Demonstrated the differences between the baseline GFR and the stress GFR in normal and pregnant women at different stages. So basically what they found was in pregnancy there is naturally physiological hyperfiltration, and to achieve that hyperfiltration and to achieve that supranormal creatinine values, these pregnant women use up their renal functional reserve. And in comparing the first and third trimester, by the end of third trimester, the renal functional reserve is used up more to maintain the same amount of filtration. That's what they found. So it's solitary kidney. So considering that somebody has 100% of the nephron mass, they might go up to GFRs of about 180 mil per minute. And if you remove one of their kidney, 50% of nephrons, so they lose all this residual function. Their baseline GFR still appears normal, 110 to 120, but they don't have any reserve capacity. So we'll go over briefly about the methods used to elicit this renal functional reserve. So in 1983, Bosch et al. Described renal function test by giving oral protein load about 80 grams, and by that they estimated the stress GFR and they calculated the difference. In 1991, V. Nicola did this test in hypertensive patients, and he used amino acid infusion instead of oral protein load. So it can be both elicited by oral and IV loads of protein. And so in most of these experiments, GFR is measured by insulin clearance, and renal plasma flow is measured by para-aminohepatic clearance. And iodinated substances also have been used to elicit these things. So here I describe a method from the commonly cited article by Sabine Zita, published in Nephrology, Dialysis and Transplantation in 2000. So to do this test, subjects are instructed to eat a low protein diet for 2 days before the test. They are kept NPO the night before the test, and after they're there for the test, they give 4 milliliters per kg of water every hour, and they determine the clearance. So that would be the baseline clearance determination. After that, they give a test meal, which is usually 1 gram per kg of protein loading, and after 90 minutes of the protein loading, they determine the second clearance. So that would be the stress GFR, and they calculate the difference, and that would give you the renal functional reserve. So in our example, they used 1 gram per kg of protein, and they used For example, in a 70 kg subject, they use 40 grams of liquid and 30 grams of powder. I don't know exactly why. I didn't find that exactly in the article. Maybe it's difference in the amino acids in each of those. And so to determine the GFR, they use a substance called sinistin, which is an inulin-like polyfractosan, and to determine renal plasma flow, they used para-aminohydrate. So, as we said before, I mean, they can either use oral protein loading or intravenous amino acid infusion. In this protocol, they chose oral because in the previous experiments, it was shown that if you give intravenous, it might cause local phlebitis and pain. So to avoid that discomfort, they chose oral. And they chose 90 minutes because they gave the test meal and they checked the stress GFR after 90 minutes because in the previous experiments, it was shown that the GFR responds about approximately 1 to 2 hours after the previous the protein load. So the most like average time was about 90 minutes. So that's why they choose that duration. So what is the mechanism of this increase in GFR with protein load? First thing is nobody exactly knows. As of now, we don't know exactly. But there are a lot of things that are implicated by different investigators. So out of them, important things are nitric oxide. Obviously, it's potent vasodilator, so that's the reason. And prostaglandins, glucagon, and the growth hormone. So here I'll tell you about mechanism proposed by Woods. That's one of the other commonly cited articles published in Kidney International in 1993. Woods says that you ingest a protein load, there is acute rise in the plasma amino acid concentration. They get filtered at the glomerulus level, and they stimulate a state of proximal tubular reabsorption, and they might alter the sensitivity of macula densa by altering the cell permeability. So they increase the proximal tubular reabsorption. There will be inside the tubule there will be a low sodium and chloride. And macula densa stimulates the release of endothelium-derived relaxin factor or nitric oxide and prostaglandins locally, and that dilates the efferent arterioles and causing the increase in glomerular filtration rate. And this mechanism proposed by Woods does not have does not tell about glucagon, but the role of glucagon was well documented in the literature, though we don't know if it's really the primary mediator of RFR or not. So plasma glucagon concentrations rise up. Go ahead, sir.
Excuse me, I have a question. In normal situation, isn't it that when we have increased absorption of sodium and chloride, the proximal tubule, the afferent arteriole will constrict?
So, as of I understood, it says that the sodium is low in the tubule. That's what it senses. So that means it perceives it like a low GFR state, and it tries to increase the GFR.
Because when you have a lower concentration of sodium in the macula densa, kidney will sense that you are dehydrated. You are losing, so we try to avoid the.
Just to understand what you said, like if there is a lot of sodium and you are absorbing a lot of sodium, it senses like it wants to decrease the GFR instead.
That's the mechanism why prerenal GFR, prerenal azotemia, we will have just constriction of the afferent.
Yeah, that's a tubular glomerular feedback. As per them, it appeared like the cell permeability is altered and the sensing mechanisms are also altered. That's a postulation. We really don't know if it's true or not. So by altered mechanisms, it senses after the reabsorption, it senses the low sodium load in the lumen, and then it does like increased GFR. That's what is postulated. And yeah, so plasma glucagon increases after protein load, and also if you give pharmacologic doses of glucagon, they cause a rise in GFR and renal plasma flow. And to support this, pancreatectomized dogs and humans showed to have no significant renal function reserve. And other supportive evidence is that somatostatin, which inhibits glucagon, is shown to block the response to protein load. So they did experiment Castellino in humans and Freeman in pancreatectomized dogs, and found that there is no significant renal function reserve, so it supports the role of glucagon. And other people postulated the role of growth hormone, but it was inconclusive. And some other studies showed involvement of prostaglandins. And some people also say that there might be a role of renin-angiotensin system in this, but following a meal, following a protein meal, there is no significant elevation either in angiotensin 2 or plasma renin activity. But plasma aldosterone liver.
I just had a quick question. Do you know if there's any direct effect of amino acids on the renal hemodynamics? Because it's possible that the free amino acid might be acting directly on endothelial cells rather than through the sodium, and that would explain maybe the conflicting thing that Amir was raising, and also the effect that if it's mediated through salt, you would think the rest would have an important role in it, right?
Yes, so that's a very good question. Actually, there is no published data regarding that, but recent review article by Dr. Sharma and Claudia Ronco, it talks about this, and it says that possibly the predominant mechanism could be effect of amino acids on the vasculature, and they predominantly increase the renal blood flow, and the increase in renal blood flow increases the GFR. And that's what they found by experiments in their labs, but the data is unpublished yet. So maybe we can see that publication. Basically the role of renin-angiotensin system is also inconclusive. We can't usually block it by giving ACE inhibitors, so we don't know. But in some disease states, like in diabetes, they might say there is some effect, but as of now it's inconclusive. And nitric oxide, I mean, it's a traditionally known vasodilator, so many people said it might have some role, but we don't know exactly. And dopamine and liver hormone, it's a hypothetical hormone called glomerulopressin, have been proposed also. So this is a table from some old article which shows all the chemical substances implicated in renal function reserve. Glucagon, growth hormone, insulin, prostaglandins, renin-angiotensin system, kinins, nitric oxide, dopamine, glomerulopressin. So, but anyways, to simplify, important things to remember are either alteration in the tubular-glomerular feedback or glucagon mediated in some way, and the flow mediated, like you said, with increase in the renal plasma flow. So which amino acid? So experiments are done with usually amino acid mixture. There is no single amino acid that was implicated as sole contributor to this, elicitation of stress GFR. But glycine seems to be particularly potent. And I mean, it might be tempting to say maybe arginine is potent because it's a precursor for nitric oxide. However, in studies, it was not shown to be solely potent. Glycine is better than that. And also, the amount of protein administered alters the magnitude of response. So Rodriguez and Ito showed that RFR can be elicited even with lower doses, like 43 grams of cooked beef, and there was a dose-response relationship up to about 107 grams. So baseline and stress GFR in different states. So considering a young, healthy kidney, this would be the approximate normal GFR of 130, and the peak or stress GFR would be approximately 180. So this light-colored portion is the renal functional reserve. Same if you take non-vegetarians who ingest protein load most of the time, so their GFR, baseline GFR itself is high, and peak GFR is slightly lower or near normal, and functional reserve is slightly lower. And in vegetarians who do not ingest protein load that often, they have relatively lower baseline GFRs and higher functional reserve. And like solitary kidney, minimal functional reserve, and in elderly and CKD, it's minimized. So now we discussed about the definition of renal functional reserve, and we talked about how to elicit renal functional reserve, And now we'll see what is the implication of this in AKI. So, estimated GFR reflects a derived value of GFR, assuming that the patient is in a steady state. So in acute stage, we can't use eGFR. I mean, now we use kinetic GFR, but so basically it's not an adequate tool to determine variations in the AKI. And as we told before, the eGFR and creatinine would remain normal till about 50% of the nephron mass is lost, or till the residual renal function reserve is used up. So the lost renal function reserve makes a person susceptible to further renal injuries with relatively smaller stimuli. So like if a normal person stimulus causes decreased GFR, that means it's significant enough that it used up the renal function reserve and it caused reduction in GFR. There might be subclinical AKIs that we never see just because the creatinine was normal, but kidneys took the impact and used the renal function reserve to maintain the normal GFR. So coming to the definitions of AKI recovery, and so these are the current definitions as per acute dialysis quality initiative group consensus definition 2004 that we follow now. But based on the concept of renal function reserve and renal stress testing, maybe we have to consider changing these definitions. So as of now, complete renal recovery is defined as return of creatinine to rifle R or within 50% of the baseline. Basically, rifle R is, I'll show you the rifle classification in next slide, and R is the risk, which is the first class of rifle classification. So basically, it's within coming back of creatinine to within 50% of the baseline. That's called complete recovery. Partial recovery is patients are off renal replacement therapy, but the creatinine did not return to about 50% of the baseline. And non-recovery means patients requiring persistent RRT. And we classify them.
I'm sorry. You said 50% of baseline. Can you explain it?
Which means 1.5 times baseline.
Oh, okay, so creatinine is 1. If it comes to 1.5, that means it's complete recovery.
Yeah. And so to classify patients as ESRD, we use cutoff of about 90 days. However, studies have shown that kidney might take up to 12 to 18 months to completely recover. We ourselves have seen some patients. They were discharged to rehab after classifying them as ESRD, but they were making urine, and so they were off dialysis. So it's quite possible. So just for your recollection purposes, rifle classification of AKI. This is risk, injury, failure, loss, and ESRD. It's very similar to the KDIGO AKI definition that we commonly use in the clinical practice. So risk category is analogous to KDIGO 1, AKI stage 1, with increased creatinine to 1.5 times baseline or reduction in GFR greater than 25%, and urine output less than 0.5 milliliter per kg per hour in the last 6 hours. And injury is analogous to current AKI stage 2, which is increase in creatinine to twice of the baseline, a GFR decrease more than 50%, and urine output less than 0.5 ml per kg per last 12 hours. And failure is analogous to stage 3, which is increased creatinine like 3 times the baseline, or more than 75% reduction in GFR, or creatinine more than 50, and urine output less than 0.3 ml per kg for the last 24 hours, or complete anuria for 12 hours. It also just says loss, which is persistent AKI for more than 4 weeks, and ESRD for more than 3 months. So, but in AKI stage 3, all these things are included. So current KDIGO says that once you are initiated on renal replacement therapy, it's AKI stage 3. This is the KDIGO guideline stages 1, 2, 3. So these definitions do not consider the role of renal function reserve in the final evaluation of recovery, because in subclinical AKI, we might not see reduction in GFR unless the RFR is used up. So, as we said before, patients become more susceptible to less severe stimuli if their renal function reserve is lost. So, if somebody has subclinical AKI, they might have had normal creatinine, which nobody realized, but they might have already had subclinical AKI. And with a smaller stimulus at a later stage, they might develop AKI. So this graph represents that. So this is normal baseline GFR, and somebody has kidney attack or AKI, some stimulus that causes AKI. There will be reduction in the GFR. This is used up. However, the baseline creatinine remain normal, and in some cases, it might go back to normal renal function. So it might recover almost completely or partially. And this patient, ideally, you should classify them as subclinical AKI, but in clinical practice, we don't see them as AKI. We don't classify them as AKI because the creatinine was always normal. There can be some patient admitted for something that nephrotoxic medication, but creatinine remained normal at the time of discharge, but nobody knew that they had some impact on the kidney. And next thing, when they get AKI, stimulus for AKI again, so this time renal function reserve is used up. It's already slightly low to begin with, and now there is a drop in real GFR. Then we say, oh, it's AKI. And once the creatinine comes back, you fluids or you take off the offending medication, the creatinine comes back, or you say, oh yeah, it's completely recovered AKI. But we are missing the fact that the renal functional reserve is very limited here. Here, when it recovered the subclinical, it went back to normal. Here, it's not. So in the clinical practice, we are classifying this as AKI, the complete recovery of AKI. But ideally, based on the concept of renal functional reserve, we should classify this as only partial recovery, because the patient is going to be susceptible to smaller insults and is going to get more larger elevations in creatinine at a later stage. And ideally, this we should classify as recovery, complete recovery. I mean, if the RFR returns to normal. So here, quickly, I'll show some clinical data regarding RFR as a prognostic factor in different scenarios. So in normotensive systemic sclerosis patients with the normal renal function and no urinary abnormalities, they followed them for 5 years, and they found that the reduction in creatinine clearance and development of microalbuminuria or hypertension, those patients with reduced renal function reserve at baseline, they develop these abnormalities after 5 years. And CKD patients at various stages, as we talked before, definitely CKD patients have low renal functional reserve. And it is, in a study, they determined that RFR falls from about 23.4% in normal controls to 6.7% in stage 4 CKD.
We can go back
Sure.
to, so in those, when they, in this study, did the microalbuminuria and renal function reserve were independent of each other? Or?
In people with low renal functional reserve to begin with, they were found to be having higher incidence of microalbuminuria.
Independent of the microalbuminuria?
Or independent of baseline microalbuminuria, I mean. As of I understood, they took normal healthy subjects, I mean, like without any renal abnormalities in the first place. So, I mean, like to begin with, they identified renal functional reserve in patients with systemic sclerosis with no renal manifestation. So I assume there was no albuminuria there.
What did they use as normal? Because in population studies, even normal levels of microalbuminuria predict risk in a linear fashion. So were they using a cutoff of 30, or did they go all the way down?
That thing I'm not sure. But as I said, no urinary abnormalities. I thought maybe it's less than 30, but I don't know exactly. Renal function reserve in normotensive and hypertensive pregnant women, when they compared both of them, hypertensive pregnant women had less reserve compared to the normal, and they're at higher risk of developing kidney disease at later stage. And same way, obese hypertensive patients and lean hypertensive patients, obese patients had less renal function reserve. And coming to its importance, it can be determining renal function reserve can be of particular importance in determining the health status of the kidney donors. It's not unusual that we saw patients after transplant, for some reason we biopsy, either because the creatinine is not coming down or creatinine went up, and there is no, on the biopsy there is no rejection, but it's just like profound donor disease, moderate to severe donor disease. So I myself have seen 2 or 3 cases like that. So maybe we have to evaluate donors with this stress testing. So yeah. So basically, just this slide lists the possible uses and future importance of the renal functional reserve. So it is of prognostic value in high-risk groups like hypertension, diabetes, PCKD, solitary kidney, who might be facing acute interventions like contrast or undergoing surgeries or some nephrotoxic medications. Actually, I remember a recent consult called by the Burns Unit critical care fellow. The creatinine was 0.8, and they called for a renal consult saying that, oh, this patient, we are giving like highly toxic renal medications, aminoglycosides, we want your input, what to do about it. At the time, that concept seemed silly to me, but really looking at renal function, so maybe this is a time we should intervene and see at how much the patient is at developing AKI with all these medications. At the time, I joked about it with my colleagues, but now I think it's probably a valid concern, at least in future. And to evaluate kidney donors, obviously we talked about it, and to make a better clinical risk assessment prior to major surgeries, and to evaluate the level of recovery after AKI. And apart from renal functional reserve, which is predominantly glomerular, there is a tubular stress test also, which basically studies the impact of giving creatinine and the tubular creatinine excretion as a sensitive index of functioning renal mass. So in this, patients are given a large creatinine bolus, approximately 1 milligram per kg, targeting a rising serum creatinine to 4 to 6 milligram per deciliter, and then urinary creatinine excretion is measured. So if somebody has impaired tubular function, obviously their creatinine excretion is impaired, and that way it helps us to determine the tubular capacity. Some of the tubers might have been lost, and or they're not working properly. So furosemide stress test, this is relatively newer concept. So, I mean, even though it's newer, I see that actually our South Tower surgery people, especially under Dr. Bihorak, I saw critical care residents note saying that, oh, we'll do furosemide stress test in this patient today. So at that time, I did not know. I felt embarrassed being a nephrology fellow, I didn't know that. So I read about it now. So it's basically has some prognostic importance. It is also a tubular stress test. In this case, Chawla et al. Have described a method. They gave 1 milligram per kg of Lasix. In the patients who were getting diuretics previously, they used a little higher dose, and they checked urine output in about 2 hours. And if the urine output was over 200 milliliters, in those people, it has been indicated that they have higher likelihood of recovery, and the people with low response had higher recovery, higher incidence of progression of AKI. So it has prognostic significance, and it is being used at chance also. And it has an AUC of 0.87%. So, I mean, just to compare, if you calculate FeNA and FeUria, they have AUC of about 0.5, which is nothing more than flipping a coin. So this definitely has some importance. And Koiner et al. Concluded that furosemide stress test has outperformed the urinary biomarkers in the prognostication of AKI. So recently, this dipstick called a NephroCheck has been approved by FDA to recognize AKI at early stages. It basically identifies urinary biomarkers of AKI, tissue inhibitor of metalloproteinase 2, and insulin like growth factor binding protein 7. They detect these things with dipstick in the urine and determine the risk of AKI in patients. So Koiner et al. Have found that compared to this NephroCheck, furosemide stress test has a better ability to prognosticate AKI. And there is a current study which they are recruiting patients in Mexico. They are studying furosemide stress test as a predictor for tubular function in CKD patients.
What happens in patients who have non-oliguric AKI? How do you do it?
I don't know. I don't know if it's used only for oliguric because I mean there is no point in non-oliguric
Because
patients. Yeah.
the way you measure the output is the outcome is the urine output.
Yeah. But in 2 hours, 200 cc's, yeah, maybe depends on human output. I don't know. And it's also useful to determine when the patient should be taken off CVVH. Currently, we use only urine output as the marker for taking them off CVVH, or we use the coming down of creatinine more than expected to remove. But some people argue that we can use furosemide stress test to see if they would respond better and take them off CVVH before and avoid any hypertensions or anything. I mean, take them off relatively early. Future, we just need more studies and I mean with different kinds of people, different patients with different comorbidities to be involved in the studies and like assess the RFR, and also we need a better technique. And it might not be always practical to use this protein load and do this cumbersome test in clinical settings. So I'm done. Thank you. Any questions?
So is there any correlation between initial filtration fraction and renal functional reserve?
You mean like at baseline? So if somebody has a high GFR at baseline,
Do we have a high GFR with a very low filtration fraction or a very high filtration fraction? The reason I asked was probably within 5 years, there's going to be a number of companies that will allow you to measure GFR and filtration fraction at the bedside with, with just injection of fluorochromes. And so that's coming, so it will make it much easier to get those numbers. Whether that will be clinically relevant without some sort of challenge is the real question.
I'm not sure. I didn't come across this in my review.
So you said like,
That's okay.
you said like, it's like a hypothetical question. I'm just wondering, maybe I'm just thinking out loud. So you said like pancreatectomy in some humans, they did not have any renal function reserve. So, for example, if a patient like it's a kidney donor and he's already using up his renal function reserve, and he or she gets a pancreatectomy, like a surgical for trauma or some other reason, do you expect his or her creatinine to just double up all of a sudden?
No, because I mean, by kidney donor, you said that that guy has already donated the kidney,
Right.
so he is a person with solitary kidney.
Right.
He doesn't have any renal function reserve at all.
No, because he's
So-
using up renal function reserve.
I mean, he already used up. So basically, one kidney is gone. That means 50% of the nephron mass is gone, and in the remaining 50% of the mass, his creatinine is near normal.
Right.
So to maintain that near normal creatinine, he has almost used up all his GFR.
So
I mean,
he needs like glucagon and those kind of things at that point of time to be able to use it.
or to be able to
So
use
is
it.
it like a continuous thing, or once you achieve it, it doesn't matter? I don't know.
That's a very good question. I don't know if they did studies with single kidney people, pancreatectomies. I don't know. I mean, those that did pancreatectomy studies were very limited, so I don't know if there was a particular cohort
I
with
agree.
single kidney.
I was just it was
But that was a good thought.
Yeah, so maybe I'm looking at this in a kind of simple-minded way, but it seems like the commonality here of these stress tests, to be perfectly honest, is hyperosmolality. Whether it's hyperglycemia, whether it's an amino acid infusion, it's all hyperosmolality. So how do you know that all that you're seeing really is just an increase in the GFR in response to an osmolar load?
Could be, but
In which case this is not indicative, prognosticating of anything.
but with every osmolar load, does it increase the same way?
I don't know, I'm just saying, I mean, it just seems like,
Because I mean, even though they said actually they said they implicated increase in glucagon after a protein load rather than the glucose itself as being stimulator for I mean, glucagon is not similar to glucose, but instead of glucose, there's a glucagon. So you're saying that glucagon is stimulating glucose and probably that's causing osmotic effect?
No, what I'm saying is that I think in pretty much any situation where you cause hyperosmolality, you're going to get a transient increase in the GFR. Now, if you, I mean, of course there are exceptions, poisons, but honestly, I bet if you should, I would be interested to see, not that you would ever want to do this experiment, but it would be interesting to see what happens to the GFR transiently in someone who gets an ethylene glycol toxicity or something like that. Huh? Mannitol, yeah.
I'm sure that would, I don't know the literature, but that probably could that would be a good control.
Yeah, so that's, and the other thing is I just wanted to make a comment about your comparison of the furosemide stress test with the FeNA. The FeNA was never meant to be prognostic of anything, okay? The FeNA is meant to be diagnostic. So I think to say that the furosemide stress test has a greater sensitivity and specificity compared to the FeNA, I think is a little bit unfair.
Yeah, I mean, it's just that that sounds good, but sometimes in recovering AKI, we repeat FeNA to see how they are recovering. And
No, we repeat the FeNA and recovering AKI to make sure that people aren't being made too volume depleted during the recovery process, not so much to prognosticate.
I mean, yeah, that's definitely true, I agree. But even in patients who are not in the polyuric phase of ATN, even if the creatinine is not improving or slightly worsening, we tend to repeat FeNA and FURA. That's a common practice I saw.
Right, I do that quite often. But again, I think it's done more for diagnosis rather than prognosis.
Yeah, I don't think there's any data on FeNA as a prognostic tool. Plus, if you're selling the basics test, it's good to see.
Yes.
So coming to your point that this hyperosmolality,
which I will admit is not a very well thought out one.
I just say would increase this GFR. Is it that in patients who have some degree of reserve renal function, only in those patients a hyperosmolar load would increase it? Can it be used?
Well, no, but so you're talking about elderly patients, for example. You do this renal stress test in elderly patients. Well, I think the problem with that is there's a lot of reasons why elderly patients might not be able to increase their GFR. Okay, they might have severe atherosclerotic disease in the arteriolar and one high up small artery. So there's just plain delivery of renal plasma flow might be impaired just because of vascular disease or because of tubular dropout. So if you have an elderly patient who has a creatinine of 1.5 and a GFR of 35 or 40, that just might represent significant tubular dropout with ensuing tubular glomerular feedback, and therefore a significantly decreased capacity for renal blood flow, renal plasma flow, and quote-unquote response to stress. Having said that, I think that there is a concept of renal stress. I think you see it all the time. I'm just wondering about these particular protocols, and all you're really seeing is just a response to hyperosmolality.
Maybe, but maybe it's responsive to hyperosmolality, but whenever you eat some meal, there is definitely increase in GFR, right? So, but it's not estimating the renal functional reserve because the GFR might be just increasing from 90 to 120 after that. But because in the test protocol we are giving 1 gram per kg of protein, we are able to elicit this full response. Maybe high osmolality is increasing the GFR, but maybe for that to elicit the complete renal functional reserve, maybe we need higher dose. I mean, maybe that's one of the mechanisms.
Maybe it can be used, to see, how fit your kidneys are. Like with the cardiac stress test, when you put stress, the contractility increases. If you have a bad heart, it doesn't go up. So in possible kidney donor evaluation, this test can be used to see if they can, the kidneys can compensate by increasing the GFR to find out how fit the kidneys are. I don't know.
Well, if you were going to do that, you would have to do it as a repeated measures thing because, you just sort of take this I mean, what's your endpoint going to be? Are you going to reject someone to be a donor because they don't have a 10% increase, a 15% increase, a 20% increase?
I mean, at least we can classify donors as like low KDPI, high KDPI, maybe. Like the extended criteria donor rather than rejecting or accepting.
There's going to be a development of living donor KPI, which is, I don't know if you guys are aware, but in deceased donors, there's a new donor ranking system for deceased donors that went into effect in December. And they're looking to extend that to try to make the same donor profile index in living donors as well too, but that hasn't been officially put out yet.
So this would come into play when you compare donation or
Yeah,
just